Welcome, everyone. We will get ready to start our 2 o'clock session. I'm Devi Nair. I'm one of the very few electrophysiologists at CVI, so thank you for having me at this structural meeting. It's always fun to learn from all my structural colleagues and imaging colleagues and get to see them a couple times a year. So we have a great panel with us, great set of speakers, and my co-moderator is Nadira, who is very well known to all of you, so I don't have to introduce her. Without much ado, I'll start with the first presenter, Dr. Clifford Kavinsky, who's going to tell us, this is a session on ultimate closure cases, and we have some ultimate speakers, so. Here. I still remember his case from last year, so
yes,
let's
I
see
remember,
whether he beats it or
all
not.
of us were sitting here last year. Thank you very much for inviting me, my esteemed panel. I'm very impressed to be here and presenting in front of them. We're going to take a break from TAVR. I promise you we're not going to talk about leaflet overhang one time. So they always count on me to bring an interesting left atrial appendage closure case here, and I hope I won't disappoint. These are my disclosures. So brief history, 77-year-old female, history of coronary disease, bypass surgery, hypertension, hyperlipidemia, of course atrial fibrillation. She has non-Hodgkin's lymphoma, esophageal achalasia. She has moderate AS, velocities and gradients in the mid-3s and 30s. She has recurrent GI bleeding due to AV malformations requiring hospitalization and repeated blood support. CHADS VAS score of 5, has blood score of 4, referred for left atrial appendage occlusion. This was done in Boston, where I am on staff at the BI. Here's the initial imaging, focusing on the aortic valve. You see the aortic valve is extremely dysmorphic. She has moderate aortic stenosis. She also has mild aortic insufficiency. I think you all agree. So here's the initial procedure itself. Chicken wing morphology, 18-millimeter orifice, depth of 20 millimeters. We used a 24-millimeter Watchman device. Device was placed in the usual fashion, like you all know how to do. 16% compression, no residual leaks. Tug test was good. Device was successfully released. Patient was discharged on Eliquis. And normally that would be the end of this story, but for this conference it's not. 45-day TEE. Watchman device is not where it's supposed to be. It's sitting in the left ventricular outflow tract, right beneath the aortic valve. Remember, she has moderate aortic stenosis. The proximal end of the screw is turned towards the anterior leaflet of the mitral valve. Device is remaining below the aortic valve, and the central pin was actually oriented towards the ventricular septum. So that's the situation. Color Doppler shows that there wasn't an acute left ventricular outflow tract obstruction, but there was, of course, a loud murmur of aortic stenosis. This is the 4-chamber view showing the device sitting right there. So what to do? The device is in the outflow tract. Patient has moderate aortic stenosis. She has aortic insufficiency. What to do? So I turned to my panel and want to get any feedback you might have, suggestions.
I would definitely say as an EP, I don't like going by the aortic valve anyway. So I stay away from that valve, especially with a valve like that. I would go transeptal and try to maybe push it, disengage it a little bit and try to get it that way. But the concern obviously is going to be the mitral valve apparatus.
So you would go transeptal to try and pull it?
At least move it and see if I can, if the patient is not agreeable for surgical. But to me, that is the patient.
So your first choice would be surgical
I would definitely
removal.
consult surgery to see if the patient is agreeable for surgical eval.
Okay. Nadira?
I mean, yeah, I think so. I think going transeptal is possible. The angles there are very challenging. You're going to have to kind of retroflex and all the cords and everything, and you're going with a Raptor. I mean, so I would probably come retrograde across the aortic valve, and the patient has moderate AS anyway, so you have a reason to put in a TAVR valve to follow if needed, if there's damage. So try to extract it retrograde across or antegrade across. You cross retrograde, but extract it antegrade through some type of sheath And
Sure.
that's going to be the challenge, to find a long enough sheath. So, and then follow with the TAVR if needed.
Dr. Null?
I agree. I think, has this patient had their TAVR evaluation with CAT scan and things
No.
like that prior to all of
It
that?
was moderate AS. That was what it was billed at.
Yep.
She's New York Heart Association Class 1, no evaluation.
I do think going retrograde across that aortic valve would be easier to snare that Watchman device as opposed to trying to cross the mitral, the angle of going into the LVOT, and then the concern of getting caught up in the apparatus, the mitral valve apparatus afterwards. So I think it would probably be easier to go from a retrograde approach. And then there was calcium on that initial TEE, so presumably a TAVR valve would anchor if you were to damage the aortic valve in the process. So you have more of a bailout in that situation.
What about you, Dr. Voudris? I trained Dr.
The
Voudris,
device,
by the way.
I want to just say the LA device had quite a muffin top on it. You know what I mean? It was
Yeah.
There was a big shoulder all the way around,
Right.
not just in the 135 where you normally see it, but I think in the 90. So that it was probably a little proximal in its original deployment.
The
I mean,
original deployment, I would agree.
I agree. I think I would do the same. I would cross the aortic valve, be ready to injure those leaflets. You got to
So you're
be
agreeable.
come by. And,
I have to admit, the approach across the mitral valve transeptally, I thought was fraught with difficulty. And the patient did not want surgery. I'll tell you, she was very candid about that.
For us, that I think it's a great time for us to call the structural colleagues into the lab and say, my structural colleagues don't do Watchman, so I'll pull the valve, you fix the valve that I ruptured, I guess.
Any other opinions from the audience? So I think there was a extensive conversation with the multidisciplinary team, cardiac surgery, electrophysiology, interventional radiology. Everybody was there. A reluctance to undergo surgery. A percutaneous approach was decided. We, after a lot of discussion, decided to go with a retrograde approach and support with an anterograde transeptal LA access in case that we needed bailout and the device migrated back into the ventricle. So we did it in the hybrid lab using TEE and general anesthesia. We had cardiac surgery and perfusion support on standby should a sternotomy be required. So this was our equipment. We used right transfemoral arterial and venous access, 8.5 Agilis through the previous IASD from the original procedure. We used a 40 centimeter, 20 French Cook sheath, which we telescoped an 8 French shuttle sheath and a 5 French AL1. So this is, we wanted to telescope this equipment. Here's the original images. Now what I've tried to do is to correlate the fluoroscopic views with the corresponding echocardiographic views obtained simultaneously. So here, I think we're using a V18 wire, and we're trying to pass the wire through the structure of the Watchman device. Obviously not through the fabric, but through the stent struts that it has. That would be our ideal plan. Here's the initial image. And we successfully passed a wire either through the device or adjacent to the device, and you can see it on the corresponding echo image. It looks like that the wire's going through it. I can't tell for sure. So then what we did was work the shuttle sheath down just beneath the aortic valve, right up onto the device. And then through that, we took a alligator tooth raptor, and we tried to put it through the shuttle sheath and try and grasp one of the stent struts on the Watchman device. And I've just shown the raptor here, so you know what it looks like. And here's the raptor going through the shuttle sheath, trying to grab onto the Watchman device, trying to follow the V18 wire. And I think you can see on the echo image that it is right there. And we are able to, we did grab onto it, and then we sort of dragged it across the stenotic aortic valve and popped it into the aorta. And there you can sort of see it. And what we did was we pulled it down, then we pulled the whole apparatus down to the cook sheath, the 40-centimeter cook sheath that we had down in the aorta. And once we had it down there, the question was, how are we going to get it into the cook sheath? We had it stabilized with one of the Raptor devices, but we didn't feel that that was enough support. So we put another Raptor right next to it. It fit through. So we had two attached devices for extracting it. And with the combination of the two devices, we were able to pull it into the cook sheath. And here you can see final angiogram showing no damage to the aorta, and an aortic root injection showing that the aortic insufficiency has increased. I think you would all agree. And you can see on color that the AI has increased. But I don't think it's severe yet, but it's certainly more than it was at the beginning of the case. And so the key learning points here are no matter how many left atrial appendage occlusion devices you do, all of you do them in this room, it's not as simple as we think. And I think a structural proceduralist, a properly trained one, has to not only be good at the procedure, he has to be good, or she has to be good at recognizing complications and dealing with the complications of their procedures. If you have to be comfortable with snares, you have to be comfortable with retrieval devices in order to be a competent structural proceduralist. And the importance of multidisciplinary team discussions are really important in getting consensus for these kinds of techniques. With that, I'll stop here. Thank you.
Amazing case. I mean, you know, for us imagers, I think the key as well is making sure, like you mentioned, you know, to avoid these kind of complications, right? I think that's the other key learning
The best
point.
way to avoiding, to dealing with the complication is not to have it in the first place.
That's right.
Yes.
So the learning points, you know, from understanding the pre-procedural planning, the sizing, I think we spoke a lot of it last year. I think that's one of the other key learning points as well. And I think we have a question.
Yeah, it was all there. You know, we had the surgeons right there. We had, we do ECMO in the cath lab. We're always ready. It's a hybrid lab, so we can open the chest right in the same room.
Assuming you had carotid protection and everything when you do it this way, or?
We tried, we had trouble placing the Sentinel device, so we had to abort. You know, that device, either it goes in or it doesn't go in.
So are you going to do another left atrial appendage occlusion device for this patient?
I'm sorry?
Are you going to do another
So she
occlusion
wants
device?
it. At the time, she hasn't had it yet, but she's very willing. She already has the IASD. All we got to do is go in and put a maybe an amulet this time. Thank you all very much.
That was great. Thank you. And moving along, we have Muhammad Saric, who's going to talk to us about the ultimate closure case number 2, leak and management in left atrial appendage closure.
Hey. Absolute pleasure to be here. So I'm an imager, so I'll show a lot of images with you. There's, and you see, I called it left atrial leak, post-surgical leak, case that I've never seen before. I've been doing imaging for 30 years, and probably you haven't seen the case that I'll show you. So these are my disclosures, and so I'll divide this presentation in 2 parts. So first, I'll show you the cases that I have seen, the sort of what the standard surgical leak looks like, variety of surgical approaches, and then I'll show you the case that I've never seen before. It's a surgical close, so let's take it away. So let's start with the cases and sort of set the stage for what I'm going to show you. So these are the standard, okay? So as you know, I mean, the most of these talks are about the transcatheter closure of the left atrial appendage, but surgery does still play a role in closing left atrial appendage, particularly in conjunction with other cardiac surgeries. And you may not be aware that actually the first surgical exclusion of the left atrial appendage was actually amputation of the left atrial appendage, and by a fellow New Yorker, John Madden, 1948. So he did left atrial appendage occlusion, but if you see the title of the paper is a prophylaxis of recurrent atrial emboli. So the surgical way to prevent atrial emboli. Huh? So we can say, wow, why would you do the surgery if this patient has a rheumatic mitral valve disease, what we'll call now valvular atrial fibrillation. But you remember that essentially this was a decade before warfarin was even came onto the market. And you see one of the first recipient of warfarin, if you're a good, important person like Dwight Eisenhower, he was one of the first to receive warfarin. But essentially then the surgeons really turned into some form of a suture technique and suture closure of the left atrial appendage. And it's particularly common with the mitral valve surgeries. And here I'll show you on an unfast view 3D image of somebody with the surgical, in this case, robotic mitral valve repair with an annuloplasty band. At our institution, it's a CG band, or Colvin Galloway, two surgeons who invented this. But not only that you have mitral valve repair, but it's always associated with the suture ligation of the left atrial appendage. And if you see that the arrow, these are the line of sutures just lateral to the sewing ring, showing us that there is really sutures are present. The same applies if there is a valve replacement. Again, you see the line of sutures. There is exclusion of the left atrial appendage. And then indeed, if you do TE right after the surgery, you'll see that there is a flap across the left atrial appendage is closed, but there is still fluid in the left atrial appendage. But if you wait long enough, they'll be clotted off, surgical, there is a tissue ingrowth, and everything looks perfect. That's exactly what the desired way of surgically excluding left atrial appendage by suture dilation. However, it doesn't work always like that. You agree? It doesn't work always like that. And often that surgical closure does not lead to a complete thrombosis of the left atrial appendage, but you do have partial thrombus formation, which in of itself would not be a problem unless there is residual leak. There is a residual leak, and also you'll see it, if you pay attention, it's typically around the left circumflex artery, because the surgeons will tell you they will not, at the circumflex artery, will not do deep sutures to prevent damage to the left circumflex. And if you do see it, typically you will see this is the leak around the left circumflex. And therefore we know there are complications, all of this. And as actually as at NYU, at my own institution 25 years ago, there was one of the first report that shows that this suture technique of left atrial appendage leaves about 1/3 of all left atrial appendages incompletely ligated. Okay, maybe say maybe my surgeons were not, the best at the time. So let's look at another institution. Let's look at the Cleveland Clinic. How do they do? Even worse. And so it's not that it's a problem to do that. But maybe we can do AtriClip. Maybe that it's better if the surgeons do this. Maybe it's going to be better. And it's really in this is a 3D CT image. Remember that that's a blood cast. So if there is no appendage, if there is no blood flow in the appendage, there is no appendage. And this is beautiful. This is exactly how it should look like, the closure of the left atrial appendage. And then we can actually watch it, how the left atrial appendage. So this is unfast view 3D TE of the left atrial appendage. And then if you just watch enough, you see that the surgeon closes with the AtriClip, and you expect this is really nice, and that's how it should be, huh? That's good. Then you do TE images, and it's really left atrial appendage is excluded. You put some color, absolutely no color. Beautiful, huh? This is exactly. And essentially, do we know how this works? LAAC 3 didn't test against device itself, but it's actually a combination of device anticoagulation versus anticoagulation, so we don't know. Even if it's properly placed. However, it's always however, huh? There is really, you can be like this. This is almost like a comically placed closure device that essentially the entire left atrial appendage, but it's even worse that the distal part that was closed, not even the entire length of the appendage. Okay, and then if you put color, there is a massive sludge in the stump. And as you know, there are some stumps that are big enough that you could put a Watchman or amulet device, and I presume we have all seen that. Okay, and then all the images that I showed you, actually, I contributed to the latest European guidelines of left atrial appendage from 2025, and this is the reference if you are interested. Okay, so now let's look at the case that you're waiting for. This is the case that you have never seen. Okay, so this is case presentation. So 74-year-old woman presents for possible cardioversion. And we look at the surgical history. She had the robotic mitral valve repair, annuloplasty band, just the way I showed you. and also had the suture ligation, just like what we are expected to be regular. And then she was referred for TE. Remember, this is possible cardioversion, and it was reported there is an interesting, unusual color Doppler flow in ligating left atrial appendage. However, there was no apparent leak. Interesting, huh? Something is not okay. So now this is a 90-degree view. You actually see the left atrial appendage. It's patent. 5 years after surgery, it's clearly patent. And then you put the color on, there is a red, blue, meaning to and fro flow, filling and emptying of the left atrial appendage. But then if you look at the typical expected in 45 and 95 next to the circumflex, there is no apparent leak. This is exactly what I showed you previously. There is, so something is not right. Okay, maybe we should look at the other angles. Always look at the other angles. This is 135. See, you can clearly see the left atrial appendage. Again, you see red, blue means that the fills, empties. But then, if you look at this, there is an extension, strange extension of left atrial appendage. Originally, I thought maybe this is an imaging artifact. It calls the slice thickness artifact. You know that there's actually two structures superimposed. You know, there is the left circumflex arteries underneath the left atrial appendage, and maybe I'm confusing this left atrial appendage. You know, maybe. Okay. So, but then let's look at it again. This is 135, and then I'm looking here. It's like really, if I freeze this image, it looks to me as if if the left atrial appendage is a frying pan, there is like a pen handle that extends from the left atrial appendage. I don't know, what's this pen handle, you know, where does it go? Okay, so let's get the CT. Maybe that will help us, okay? So now, if you look at the CT, you see there is a left atrial appendage fully opacified. So it's, despite the fact that it's a suture ligation, but then look at this. There is the pen handle is much longer than I expected. It actually extends all the way to the back of the posterior left atrium. So I've never seen this. You know, I've been doing this for 30 years, and have anybody seen this? Anybody? So it really looks like it's really, so it's interesting. So this is, and I thought maybe this is kind of unusual vessel. And I said, go to surgeon. I says, is there any anomalous vein that could be like this? He says, no, I don't know. I don't know. So I do literature search. Is there some congenital anomaly that I have never seen it. You know, I don't know what it is. So, okay, so I look at nice 3D and I move the image, beautiful. You can actually see this the annuloplasty band just above it. Parallel to it, there's this long extension of a pen handle. And then if you freeze the image, a 3D image on the left-hand side, you see really the frying pan and a pen handle. And then also you can see it on a cross-sectional image. And if I rotate my T image 90 degrees counterclockwise, it's really completely apparent. You see that the frying pan and extension. But I don't know whether that actually ends on the other side. And then if you look at the 3D CT image, you see in white, you see the sewing ring, and then the red dot actually shows you the left atrial exit of that pen handle. So therefore, it's really, if I now freeze the image, you actually see it here. This is oversewn left atrial appendage, that it's left atrial entrance of that channel, and then everything in between, buried underneath the endothelium, is this channel. So what's happening? So this is what's happening. Essentially, the surgeon oversews the left atrial appendage, but instead of stopping at the left atrial appendage, it continues sewing, so not realizing that he's lifting the left atrial appendage and unintentionally creating essentially what it's a fistula on iatrogenic abnormality. Okay, and then we can measure by CT how big it is. So let's close it. Should we close it? What would you use to close? Anybody?
Some kind of ductal occluder of some sort?
Excellent challenge, but luckily we have a 3D TE, so we can guide. Yeah, okay, but let's do it, So this is, this is unfast 3D view of the mitral valve. Am I taking too much time? Is that okay? No, it's okay. So this is the left, and we know from the CT imaging that actually the entrance to the left atrium is at the base of the P2 scallop of the posterior leaflet. So we know roughly that, and plus fluoroscopically, we will see annuloplasty band as well, but helps us with CT on a TE as well. On a TE, we couldn't see the entrance itself, but we know where the location rough is. And you see this is a transeptal, and the catheter comes, it's too lateral. I tell my electrophysiologist colleague to move it more medial, and then even more medial until we are really in the orifice, okay? So now let's look at this fluoroscopically. Yes, it's really engaged. We know exactly, and then see that there is the left atrial appendage, like the frying pan, and then this is its left atrial orifice where the catheter enters, and then that's the pen handle of a long channel where this communicates, and that explains how that fills and empties. What are we doing to use it? We're going to use AVP2. So otherwise in my lab called the Tootsie Roll. My colleague called it AVP4, we call it Hershey Kisses. So we'll do Tootsie Rolls, okay? And then we didn't know how to be honest with you, what to do with the AVP. And so my colleague, he placed it at the the left atrial appendage to close the left atrial appendage. This was a 10 millimeter AVP. And as you know, they don't have a clot, that it's just a pure nitinol. So it essentially will be, you cannot have a perfect closure right away. It'll take some time for endothelialize, okay? So this is AVP2. And so I said, it's like interesting, we really did. And then a few weeks later, another patient shows up, exactly from the same surgeon, and exactly the same, but now we know everything. You know, there's a pen handle, all of this, you know, now I become, you know, sort of experience in this. So it's really now we can measure left atrial appendage size, we can have a length of the pen handle, and then now even becoming a better TE, you know, now I know what to expect. And actually now I can actually see the distal disc of the AVP2 as it enters the left atrial appendage. Then I put the color, it's still because this is just the initial part of the placement. And then we did this, and now we see we had a now different approach. Now we use a bigger device, it's a 16 millimeter, and now we close the entire channel rather than this. Okay, it looks like Tootsie Roll, doesn't it? Okay. And then if you ever wondered what this horizontal bar is, this actually, the patient has pectus excavatum repair with the older technique called the Ravitch technique. So this is a conclusion, okay? So expect the unexpected. I didn't know what it is, but I want to thank my colleagues for really the part of this team. So thank you very much, and happy to answer the questions.
Thank you very much. Mohammed, did you talk to the surgeon?
Yes, of course. No, but it's really, that was unexpected. It's really, and the technique has changed. Yes.
I think you have to, I mean, it comes down to imaging to figure it out.
Yeah.
And to have multimodality imaging to sort it out and be able to do it under 3D TE, I think is what.
Yeah, and that's because I, learned CT, and I was just actually looking over this, and I looked at CT, and I didn't visualize. I didn't know, maybe it's a lack of my knowledge of CT yet enough that I didn't know, but then essentially continued, and it's really proven. There was really that I was scared the most before we injected, and once we injected on fluoroscopy, it's really proven that the finding is real.
Would you be following up with these patients with a CT and to see
Yes,
whether it reduces?
absolutely, yes,
Yeah, I would
CT.
anticipate it to reduce, I would think.
Mm-hmm. So absolutely, it'll be gone, particularly the second case. Yes, we do CT, we'll follow up. But it'll take, I don't know, for AVP devices, the paravalvular leak, it takes several weeks, if not months, is that correct, Nicholas? Yeah, so it takes some time to,
High flow, it might, that first one I was curious, did it actually close? Because it was a very high flow.
It's high flow, it's really, we did a CT, and it's still yet to close.
Yeah.
It may never, but at least it's protected from the thrombi in the left atrial appendage.
That's the one thing about the AVPs that I don't like is that they, so sometimes I'll back it up with some coils, put the AVP and then just pack some coils next to it. And then when you leave the lab, it's closed.
Yeah, we actually considered that. But it's also, through that channel, that they do not, coils come back, it's also the possibility. But that's good. We really did consider that.
Oh, you have something to say?
Yeah. Yeah. Yeah, so we have many of the, essentially we have, because it's really, people have atrial fibrillation, and we have a CT for most of the preparation for ablation. So then essentially we go and this. So this is at least three cases that I have. Two I presented. So I hope you.
Voudris,
to
you
the
have a
intervention.
question?
And,
Voudris, yeah.
I mean, it's a thin structure, and you pretty much you call it like a little. Any concerns with the AVP rupturing it? Like you're applying a lot of pressure. Like they're kind of vascular plaques, so
Yeah.
they're used to having some like thickness around them. I agree with like coils idea of like stacking a lot of.
But tough enough to access it once, you know, to put a coil. But absolutely, I mean, that was being considered, definitely. So we are learning.
Twos, especially the smaller ones, they're very, very soft.
soft.
So probably the risk is low, but I was thinking the same thing. It kind of
Yeah.
looks like a watermelon
Yeah.
seed in there,
Yeah.
right?
So, but this one is almost a year old. I mean, nothing happened. Okay.
Oh, it's beautiful.
Well,
Okay.
thank you, Muhammad, for
Thank
that
you so much.
incredible case, always. All right, so our next speaker is going to tell us about device misfits, is none other than Vivian.
All right, so my case is more annoying than exciting as that one was. These are my disclosures. So our patient, 80-year-old gentleman, has obviously a history of atrial fibrillation. Has a lot of risk factors to make his CHA2DS2-VASc score 6. He has CAD, PAD, heart failure, CKD, and he's currently on a low-dose Eliquis, but he has recurrent hematuria secondary to renal stones and chronic thrombocytopenia. I'll also mention that he had melanoma and underwent a modified radical neck dissection. So he was referred to us for left atrial appendage occlusion. His left atrial appendage, you can see, has an elliptical orifice here. It measured 30 by 19.1 millimeters, and the shallowest depth to the appendage was 17.4. CAT scan, unfortunately, the timing of the contrast wasn't great, and there is some artifact there. But I'll just pause right here for the initial evaluation to our panel as to what their procedural plan would be if there's any concerns that they may have, device, steerable sheath, ICE, or TE. So does this seem out of the ordinary at all for anyone?
When you think about it, I would say at least 60% of the appendages are oval in a sense, but this is an extreme oval. So I think when you start thinking about single plug, to me, single plug is going to be difficult, but you will get some overcompression in one side and undercompression in the other. If you look at a disc and lobe, then you are going to end up oversizing a little bit. In one plane or the other, you might have overhanging on the pulmonary vein or overhanging on the mitral valve. Either one is not good. So I think these are cases where I like to do virtual simulation, either with FIOPS or one of these softwares, figure it out ahead of time. I'm a 100% stable person, so that's a no-brainer for me. And ICE, I think if I'm using ICE, I use 4D ICE, but if I have access to 3D TE in a difficult case like that, I would use TE because then I have a second operator that's guiding me. I like 3D TE over 4D ICE most cases, but I would be okay to go in and see what to do.
Yeah, for me, I agree with Devi. The shape of it. So I agree with probably using advanced imaging. That's why we mentioned yesterday to see like FIOPS, what works best before going into the case and pre-procedural planning. A little bit more, and then definitely steerable sheath. And for this, I'll use TE for sure.
So this patient did have the neck resections. That was the only thing. So that was why we were potentially thinking ICE for this. Yeah.
Yeah, I mean, if you go back to the CT, so you're showing us that it's very elliptical, but it's amazing when you draw that line that you're measuring.
So that line,
Okay,
sorry, when
so-
I circled through was not where we measured. Sorry, that was
Okay,
like off a
but-
little bit. Yeah.
Yeah, so my point is that depending on where you place the ostium, it can be shockingly oval. Like if you just move 2 millimeters into the atrium, all of a sudden it looks extremely oval. But if you move 2 millimeters in the appendage, all of a sudden it's a perfect circle. So you have to kind of be a little, right? You have to think about exactly where is that specific device you're using going to land. I suspect it's more circular than maybe you thought. It also doesn't look particularly deep, given how wide it is. But I actually think a Watchman would work fine here. I don't know that you even need a steerable sheath, and you could do it with ICE.
I agree with all. Pre-procedural planning is key. Like play with your CT a lot of time. What I do a lot with Nadira is actually play with your 3D T table before you start. He's really right. Like, you can come a few millimeters into the appendage, you see a perfect circle, comes oval. Like your 3DT actually has like really great on that. Like shows you like little slices and actually plan your landing zone. Real-time imaging. I would definitely do PE. Yeah. And I personally would do steerable on this one. I don't routine steerable. We just try to reserve it. Primarily try to bring like all my like greatest tool in theory, like set up myself like for success from the beginning. I'm sure like the longer you wait for it, like the more attempts you try to do, then creates a little bit of annoyance. And then
So for us, we didn't see any red flags when we did this. It was elliptical, but nothing out of the ordinary compared to what we've seen before. We're primarily a Watchman site, so we didn't see a reason to go for an amulet. Interestingly, for the audience, are people using mostly fixed curved or steerable sheaths now? So raise your hand if you're primarily gone to steerable sheaths. Okay, so most people, it seems like, are still using fixed curve. Is that correct? So we are starting to move more towards steerable sheaths, but we will often, pick and choose based on the CAT scan. Things with more difficult anatomy, shallow, chicken wings, we'll definitely do a steerable. We decided to do steerable here because we are going to be using ICE imaging because of the radical neck dissection, not doing TEE. So it does setting us ourselves up for success and having as many options as possible. And Nadira, maybe you can discuss a little bit about 2D versus 4D. Do you recommend that everybody who's going to be doing this use 4D, but the cost? So what's your recommendation for people who are doing ICE LAAO?
I would recommend the 3D or 4D ICE. I think the 2D is great as well. I think with with this complexity, and you're going to tell us why it's annoying, but I think the 4D really helps. Not only the 3D MPR, you have all those additional tools to help you. 2D, you biplane it. It's still there's some inflexibility of it to try to get to where we should. But why put yourself through that? So I think certainly that 4D or 3D ICE should work.
Yeah. So we decided to use 4D ICE for this. Again, just trying to set ourselves up for success here. So we did our transeptal puncture as per usual. We went mid here, cross the septum easily. You can see that we entered into the left atrial appendage fine. We're, maybe if we did a little bit more of an inferior stick, we would be more coaxial, but thankfully we had chosen the steerable sheath up front. So we decided to do a 31 Watchman Flex Pro initially. We tried to get the Watchman to be coaxial with the ostium of the left atrial appendage. And initially it looked like we were okay. But then when you watch on the ICE imaging, you can see actually it seems like that the Watchman device is slowly creeping out underneath that Coumadin ridge. You can see that it's starting to slip. So we try again, we recapture, and then we now, instead of being as coaxial to the left atrial appendage orifice, we now try and go a little bit more into that wing just to see if maybe we can get a little bit more depth so that this is a little more secure. And while this looked good on the lower angles, you can see that we have a very large shoulder on the mitral side, and it looked like the fabric wasn't going to cover at that side, and you can especially appreciate that on the MPR imaging. Okay, so turn to the panel now. What would you do now? This is a 31 device.
You think at 20?
So that was going to be our next step. So everybody agrees to go to a smaller Watchman. So we went to a 27, and this looked like it would sit deeper, but then we actually had almost no compression of the device. So we didn't feel like that this was going to be stable. So just on the ICE imaging, you can see the shape there, and on the angiography, you'll see the shape of the device. It's not compressed at all. So now what? Annoying, isn't it?
I would say that, and I know you said you're primarily a Watchman site, but for us, this would be the time where we start looking at amulet as a choice. But also, you know, before I jump to amulet, and there are other considerations I keep in mind, you know, the anatomy, the PA relationship, all that stuff has to be taken into consideration. And I believe that if you cannot close it percutaneously, it's okay to leave it open and maybe have the surgeon take a bite stab at it too.
Any other comments?
With the 31, I mean, that does come to the discussion of what is an acceptable shoulder in the 135. So you had excellent contact in all other projections, but the 135, you have this shoulder, right? So it didn't look like there was a leak. So that's, I think that shoulder to me was still potentially a gray area. Like you might have left that initial 31. I might have left
Initial or
it.
the second one?
The second one, the second one that wasn't coming out before your eyes. I think that might have been acceptable, but you know, that's a game day call. What's your sense about that shoulder?
It's not the shoulder that I'm worried about. I think among all the Watchman Flex devices, the 31 has the tendency to have proximal shifting the most, at least in our practice. That's how we've seen. It's the odd one out of all of them. And 31, I'm very, very careful about leaving a overcompressed distal end. You know, there's disparity between the compression between the distal and the proximal part in that second deployment. And I completely understand your worry about the shoulder and then a little bit of shift and you will have a leak because you're already at the corner of the fabric. So I would worry about a shift in that 31 and a potential leak. Or you can say, okay, if it leaks, I'm going to come back for a leak closure later and deal with it. But more than a leak, I would be worried about the stability of the device. Over time, is it going to move itself out?
Yeah, and I think also because we're using ice for this, it's, you know, you can miss leaks on ice. And just given how that looked, where the fabric looked like it was barely, you know, where the tissue was barely at the edge of where the fabric ends. For the Watchman, same thing, right? You know, one little shift that the device shifts a little bit because we have tension in the opposite direction, whether or not we would be kicking ourselves that there was a leak there. It did seem like that device was stable, but you know, having that large of a shoulder and then on top of that, the potential for a leak, we decided to try. And because we thought maybe the 27 going a little bit deeper would have been okay.
I think you send a surgeon for closure and then plug it later. That would be good.
Would anyone retry a 31 and try to see if you can get in a like different orientation, different like a little different position? See if you can get that shoulder maybe to sit a little bit better before you call it.
So while I will say that I only showed you 2 of the attempts, we did try, you know, multiple attempts otherwise, but those were 2 of our attempts and, you know, highlighting the issues that we're seeing. So we did end up switching to an amulet device in order to see whether or not it would sit better within the appendage. And so our maximal landing zone width on ice was 20, but, you know, with some measurement error, understanding that, you know, this is ice compared to our CAT scan. We ultimately went with a 28 millimeter amulet, and then again, we are deploying the lobe of the amulet device parallel or en face with the left atrial appendage orifice, and you can see on the ice imaging that it tucks in well into the appendage. And then we deploy the disc, and it covered the ostium of the appendage well. We had a good shape to the lobe of the amulet, and on the football test, the device was stable. So we ended up deploying this device and closing off the appendage. So key learning points for this is that, you know, each of our FDA-approved LAO closure devices can close most anatomies, but there are some caveats to this, with having their own design limitations. Pre-procedural imaging can drive your device selection, but obviously intraprocedural imaging is crucial in order to determine procedural success. And in this case, on CAT scan, it looked like that the Watchman device would be able to close this, but then it was the intraprocedural imaging that demonstrated that we were not actually appropriately closing the appendage. And there are new devices that are in development that may be more shape and size agnostic. Thank you.
Great case. Any comments, Voudris, Jason?
No, I was saying it was a beautiful case, like nice transition, great imaging, like your eyes was like beautiful imaging, so like the appendage great, like, well, I think it was very well done.
Thank you.
I want to ask Devi. Devi, do you have a limit to the number of recaptures and deployments you will do on a Watchman? Like if you have one that, see, you're trying to get, like this case, you're trying to get deeper, you have cerebral sheath, is there a certain number you say, okay, I'm done, like we're going to do something else later? Like four times,
Yeah,
5
I don't know
times?
whether it's quite a number, but I think with the steerable sheath and I use the Pro and I have the markers, if I can do, I mean, in my mind, I know what I can do and what I cannot do. So it's a personal limit rather than the device limit. So I'll decide, okay, this is the direction I'm going to take. Okay, that didn't work. I'm going to take a different direction. And I'll set goals. Like this is what we're going to try. And once I've kind of gone through my set plan, I'm done. It has nothing to do with the device as such. I don't think there is a device such limitation. One thing I would say is for Watchman Flex, it's usually a full recapture for me for most of the time to disengage the full device, but it's a personal goal, limit than the device limit.
Yeah, I agree. I think that it's acknowledging what you're trying to achieve with each reattempt. And not just, reattempting the same thing, understanding that with the 31, well, I accept a shoulder, yes, I'll accept a shoulder, but I won't accept that there's a leak underneath the fabric or, whether or not you're trying to get more coaxial with the left atrial appendage before switching to a different device.
Right, great case, Vivian, as always. Next one, we have Stephen Filby, who will talk to us about the choice for left atrial appendage closure success.
Hi, everybody. Paul, thanks for having me again. Pleasure to be here. All right, it's tough cases to follow. Let's see what we can do. So we're going to talk about choosing the right device for a given anatomy. This is my disclosure. Here's a patient stem. 66-year-old male, hypertension, coronary disease, had an MI, actually complicated by VF arrest, but with recovery of LV function, ultimately underwent multi-vessel PCI. Patient was a paroxysmal AFib patient who had anemia secondary to GI bleeding. Had a total of 5 GI bleeds, so kept getting admitted to the hospital. As is often the case, source of workup, extensive workup, unremarkable, so couldn't find the source of bleeding. So it gets referred for left atrial appendage closure. Chad's VASC 3 has bled 3, reasonable candidate. And this is sort of me going through a TruePlan workup, which is a dedicated software for left atrial appendage closure with a Watchman device. You can see sort of this broad base ostium tapering into the distal aspect of the appendage. I'll just play this through. And if you can see I'm just so off screen here, pulling up a device and pulling that in. So it's giving me 2 devices between 10 and 30%. I chose a device. Our program, our plan usually is to choose a device between 15 and 25% target compression. So there was the 35 millimeter device that we chose. We're going to be a little depth limited, as you can see in these NPR images, as the device is modeled inside the appendage. Might have a shoulder there. And I'm going to choose my working angle here to try and lay out the appendage and lay out as much usable depth as possible. You can see that I might be a little proud on both the Coumadin ridge and the mitral side here. So I'm getting something of an areocaudal view here. And just to sort of summarize, I've got an area-derived diameter of 27.7. I'm choosing a 35 millimeter device. I'm going to go with a Watchman device. Any concerns about that device selection? You guys feel like that's pretty reasonable?
Can you explain? I don't use this very much. So why is the device like outside the appendage? Like when it models, it's on the right, the outline of the virtual appendage is outside the outline of the actual appendage. So
Yeah.
how does that work?
This software package will automatically demarcate the landing zone. You can move that landing zone to and fro to adjust, and oftentimes we do. In this particular rendition of my workup, I did not. I just went with the computer-derived, and in so doing, it's going to show you that device is just a little proud. And also depth limited. I don't think you have a lot of room to go in with
Makes it
that
look like
device.
there's not enough room for this particular device, but maybe there is.
What were you getting for depth on your measurements?
If you look here in the bottom left, don't make me bring my glasses out. I can't. I think it's about 18 millimeters of depth. So that's, I think that's borderline 435, right?
I mean, if you had like a TAVR planning program and the TAVR valve was like outside the aortic root, like you wouldn't, you know what I mean? That wouldn't be a very good planning program. So
But
it is
Jason,
a
I
little
think
bit unusual.
this is more of an overlay, I think, rather than
Okay.
than a true. It's different than what you would see with FIOPs, where they actually do an apposition virtual implant. This is more, I think, an overlay rather than a virtual implant for that matter.
I see. So this is an uncompressed device.
No, it is a compressed
Okay.
device, but it doesn't have the AI that is going to indicate the accurate compression of the device. So there could be pectinate tissue
Right.
that eccentrically compresses and changes the way that device behaves. What it's showing you is a uniformly compressed device at around 20%. And so we chose the 35 at 21%, and let's go into the case. So we went with a 35 millimeter device. We do all of our cases, for the most part, with ICE. We use a Bayless VersaCross system. For this case, I chose a double curve sheath, conscious sedation strategy. Here's the appendage angiogram, that RAO caudal view that we had selected. Here it's showing that that pigtail is, pretty well seated, and we could stack the sheath out and calculate how much depth, but it would seem that there's a sufficient amount of depth for a 35 millimeter device. And here's our device in situ. And I'm just injecting some contrast, obviously, on the face of that device. Any concerns about the appearance of that device?
Yeah, and it's distally compressed a lot. You have you see your all the way distal in the appendage, you're very compressed, and then you're very proximal into the appendage. So I would really tag this device very well to be sure before I release it, because
A lot of tug testing is what you
Yeah.
want to do? Okay.
it will definitely.
Me too.
very
So I
easily,
did actually a couple of tug tests. I don't know if both of these are going to play, but oh yeah, here we go. So pretty aggressive tug test on this patient. And the device did not move. And the point that I was trying to get to is that cover the funnel of that outside, that funnel-shaped ostomy. I was trying to flare the proximal part of the device to try and get apposition, fabric apposition. But I look back on this this case is about 6 months old now. I went back and I was like, yeah, I was pretty smart to tug a couple of times, but we'll see if I was maybe not that smart. So I tugged on this. It did not move. Felt like it was stable. And we released the device.
Stephen, do you actually do angiograms after your tug?
You mean like flushing the? Yes, we do. Yes, we do. I did not do that in this particular case. But we also do pre and post measurements of the device. So I'll measure the compression before I tug and after I tug, so that if the device moves, that gives you another corroborative measure that if it moves, obviously the compression is going to change, right? So here, take a look at this picture here. You can see, let me just do this. Oh, come on, please. No, let's not give away the show. Please don't give away the show. So I just want to take a look at these two panels here. Take a look at this panel here. So this is appendage, like systole and diastole, and you can see the difference in how much compression that appendage. Now, this patient was a paroxysmal patient, and so there was a lot of compression. So if you look on the panel on the left, that looks like a pretty good device. You look on the panel on the right, I'm a little bit more concerned about that device. And it had a leak when it came back on CT. Now I got the CT, wouldn't you know it? I got this Friday afternoon. And so I'm thinking, oh, this is a dislodged device. Friday afternoon, do I call the patient, get the patient admitted to the hospital and do this or watch them? The sense of things that this is hanging on by a thread and, you got to pull all the alarms. And I decided that this was a 4-month CT. So the likelihood that this didn't just fall out or dislodge is pretty unlikely. So I scheduled the patient on Monday. So this was Friday, called the patient, scheduled on Monday, and here's just a still, because that last one was a little bleached out, but you can see that this device is obviously partially dislodged. It's in a position that's unacceptable. I'll just move through my strategy. So strategy was going to be a Raptor, Agilis, sort of stacking out our sheath system, but using, there's a 35 millimeter device. You have to use a large sheath in order to capture this device. And because of the position of that device, there's no way of being coaxial with the threaded insertion. You're going to be pulling that device on its side. So here's what a Raptor looks like. It's pretty scary when it comes out into the left atrium. Now, we also considered an Ono device. I think this is a very reasonable technique if you have access to it. A device is like $8,000. So when I asked for the Ono device at my hospital, they were like, oh no, you ain't getting that. So we did it, both with ice and TEE. I do all my transeptals with ice, but I think TEE to the point of, I think some of the panel participants have already made it, can give you additional imaging in this. You really want to make sure that you really get good imaging as you're trying to grab this device. Okay, so here we're dilating the septum. And if you're going to put a 24 French sheath across the septostomy, you got to do like a Rambo septoplasty here. And that just makes your ice catheter go smooth if you're going over in a single transeptal. So ice catheter goes across into the left atrium. Here's the Raptor coming in. And you can see that this sheath doesn't really allow the Agilis, the angulation hinge point of the Agilis to really do its job and perform because it's a little bit too long of a sheath. But it's what I had available on a Friday to plan this procedure for Monday. Here's the Raptor coming out. It's sort of anxiety-provoking as this thing comes out. So as the Raptor comes out, you want to make sure that you're making contact with the frame. And so you want to change projections and make sure that you are moving the device before you commit. And I would also say that you have to put a tremendous amount of pressure to pull this device out. So it's imperative that you have a second operator involved in a case like this. So someone is maintaining traction on the Raptor, and you are holding the sheath, and you working together in conjunction. And as you can see here, I've done some work on this device. You can see I fractured some of the wires of the device. If you look carefully where that Raptor is making contact, there's some of the struts are sort of hanging loose there. Here I'm making another pass at it. Yeah, I could tell that I got fabric once because I took fabric out.
So question from the panel, so why are you not using TE here for best imaging, or what is the image, this would be very hard to do just with fluoro only.
It's a good question. And that is because this was an add-on case, wanted to do it first. It wasn't a case that was originally scheduled to have imaging support. So I started it with ice, and I'm waiting for my cardiac imaging people to come. I don't have a lot of support with cardiac imaging, so I do all my cases ice only, 2D ice. And we're pretty high volume. We do about, maybe 10 implants a week, so we just don't have the sort of support from cardiac imaging to do that.
I think with the Raptor, it's a great point is where you grab it, especially if you're just grabbing the fabric. It's such a sharp teeth on it, it can just rip the fabric. I think it's so important to get one of those struts along with it. Otherwise, the worry is always, ripping the fabric. And sometimes we'll actually do a second Raptor just in case the first one decides to act funny.
Here I'm making some more progress. So literally got it. It's being pulled in. Everyone's hooray. Everyone's really happy. And then it's so much tension to get this thing through. the Raptor loses its grasp, and so it's partially inside the 24 French sheath. So here you can see I made a little bit more progress. Now here's the Raptor going into the sheath, opening up within the sheath for a final attempt at trying to grab it. Obviously, this a little bit more safe than having this thing come into the left atrial chamber. So at least we're within the sheath trying to get the device. And after some time, ultimately, we get the entire thing out. So here we are. Device is out. And let's try and close it. So what do you guys think what we should do for... What should you guys want to quit? Why? You want to quit all of a sudden? Come on, we just pulled this thing out. Okay, yeah, let's go forward. What do you want to do? So I have to say this. I'll just tell you this. We're largely a Watchman program. So last year we did 410 implants, we did 410 Watchmans, and we did 5 amulets. But this was an amulet day, which was a day of Watchman screen fail. So I had my Abbott team was there. So that did bias our plan here. I would say I'll just give that up. But what do you think? We could.
But even if it's not biased, I would say that the first attempt you tried your best to get the right device in there, and so going back and trying to do the same thing makes no sense to me. So I would have made it an Abbott day no matter what.
Okay. Anybody but putting a smaller, could put a smaller Watchman device deeper.
Well, that would have been your bailout if you don't have an amulet. So we're a big Watchman group, so that's, if you don't have an amulet, you either go with surgery, or if you really want to retry, I would try a smaller device. But at the same time, you did your numbers, you did your measurements, you felt that this is your best bet. I agree with that, Devi. It's like try to do something different when you already have made all your numbers is, I don't know how much it would work.
I think when you look at this anatomy, you can clearly see why you're 35. You had distal compression. There's difference between distal and proximal compression, and the current generation Flex doesn't allow for it as well. I mean, that'll change with the future generation when they have independent compressions that can happen with the device. But until then, I think anatomies like this that are truly bilobar with the pectinate that's so non-compliant can be challenging for the Watchman.
Yeah, I think the other thing to keep in mind is our whole methodology as to how we measure compression, I think, is flawed. We should be measuring compression within the body, where it's actually within the appendage. And I showed that very quickly, the slide of the ICE imaging and the three different planes. We're measuring compression over an aspect of the device that's actually pouched out. So yes, I was within my IFU 10 to 30% compression, but if you look at the amount of compression distally, it was probably 45%, and you don't have anchor engagement in that situation.
Yeah, I mean, I agree. I think that you actually have even less depth with this appendage than you initially thought because of those trabeculations. When you look at this angiogram, you can see that feathering of the left atrial appendage distally. And to Devi's point, with the Watchman Flex Pro, we really don't like having that type of shape to the distal end of the Watchman device because there is radial force there that will try and push you out, unlike with the 2.5 with the feet that could stay compressed without pushing you out. With the Flex Pro, there is radial force there.
All right, we're going to wrap this up. So we used, this is an amulet 22 millimeter amulet device. And I don't know, Devi, what you think of that. We felt like that was the best that we could get for this device. We tried a 25 first. It didn't work. We had good stability. You can see finally my echo imaging doctor comes in. He's like, what are you guys doing? So he drops the TE probe, and he's going to help me with the rest of this procedure after I did all the hard work. Thanks. So this device went in, and I'm feeling kind of nervous about this, so I actually ended up doing a TEE. I don't have the intra-procedural TE, but this is at 45 days. Looks okay. They felt like that there was a small amount of leak. I don't see that leak going around the device, but I certainly see it going under the disc a little bit. See a little bit of flow.
The appendage looks thrombosed, though.
Yeah,
it's echogenic. So.
Yeah. So I don't have a CT scan. The CT scan I actually obtained today, ironically enough, and I reviewed the images before I came in. It's still in place, and it's completely closed. So the appendage is non-patent, no DRT, no leak, great result. And you better believe that patient was looking at his EMR, and they sent me a note before I even could respond to the report that was done this morning. So overall, a successful result despite a complex first attempt. So my takeaways for the team and for people in this audience is that when you have these funnel-shaped anatomy, consider smaller, deeper devices or alternative strategies. If you're going to do removal, you have to do a stacking mother-daughter system where you have a steerable system and something that can really grab onto the device itself, because there's a lot of tension that has to be applied. Have a second operator there to help you. You're going to need a large sheath, especially for the 35 and the 40 millimeter devices. You're going to have to go 24 on that. And then, of course, the Raptor system, the Agilis we talked about, and the Ono if your hospital has the budget for it. So thank you very much.
All right, thank you very much. So next we have Nadira. She's going to tell us about 40 eyes only for LAAC success.
Thank you, Devi and panelists. I mean, those are great cases, and I'm going to be back to my simple stuff. So it might be boring. And when Paul gave me another 40 eyes only LAA case, it's kind of challenging. I don't have the Raptor. Voudris and I haven't used the Raptor yet. So fingers crossed we don't have to. I'll keep it simple, back down to imaging. And this 72-year-old female with persistent AFib, pacemaker, recurrent strokes, GI bleeds, esophageal varices, you hear the other cases, and really seen by EP and consideration for LAA closure. I think a lot of the sites now in the country now are using a lot of 40 eyes, shown by Stephen as well. And so this is one of the cases, she's just not able to tolerate TEE. And the purpose of this is really, thanks to Marcus, I learned a lot from him in terms of the CT and the 3D MPR roadmap. And this is the purpose of this talk. I turned it around instead of just 40 eyes and showing you, because that's what I did last year, how to do 40 eyes. And I think a lot of you know that. And so utilization of CT, I think, has been really helpful. And for this case, that was what he did. And he showed us as well in terms of how to optimize that landing zone plane, measurement of it, and really gives you an idea of where the placement of it is. We spoke a lot about it in terms of the landing zones. You can, like what Mo mentioned, looking at where's the landing zone, going the crosshairs, and establishing the depth of it as well. And so the other thing that the other speakers haven't stressed about, and which we should be using the CT, is really for your transeptal. I think we use a lot of it to determine the what's steerable catheter, right? I learned it when I was back in Colombia from Vivian and team, and from Torsten, as to how in terms of trajectory from the right side into your transeptal, because I think for transeptal for your watchman is underestimated. It can make or breaks the case, just like for mitral clip and for other transeptal punctures as well. And so we learn a lot. And for TEE, which I do a lot with Voudris, we have TEE views to help that as well. But CT, certainly a key point in terms of that. So here are a little bit of the steps I'm able to share with you, the slides, in terms of how to utilize it, placing the MPR, neither faucet, IVC, fine-tune those planes, correlate the planes as well, which we can do on TEE. And there are newer softwares like FIOPS, as what Devi mentioned as well, to optimize that plane and determine what catheters or steerable sheaths that you need to get to the appendage to your depth as well. So for this case, you can see on the left-hand side and right-hand side that ICE case simulation versus procedure. We are actually exactly the same, where the transeptal puncture, which we predicted from CT, on the bottom left, you can see the catheter in the right atrium, the transeptal puncture on fluoro. On the right-hand side, your ICE. In the RA, your transeptal puncture, you can see by the right yellow box, yellow arrow, and the trajectory of it into the LAA. The correlation is very similar. And so this is certainly what we should be doing for all these cases if you're thinking of CT and just ICE only. In terms of planning, The ostium 27, 21 millimeter, the minimum length 17. The device proposed is 35 millimeter. The FX, we did the Watchman for this, and the implant angle as well, as you've seen in the previous, using CT for your angle as well on fluoro. Just a couple of slides for 4D ICE, the assessment from left-hand side, and really in terms of the views that you saw in the previous cases, with the mnemonic for it, map it, the views, the 40, in TEE you use the 45, 190, and 135 from TEE, the equivalent of it, just to be concomitant with it with a 3D ICE, 0, minus 45, and 45. Just to know that, and this is what we did. So certainly you identify all 4 quadrants. These are the views similar to your TEE on 4D ICE. You rotate it and make sure that it's sealed, and for this patient you can see it's aligning really well. You rotate the biplane, and that's why we use a lot of the 4D and 3D ICE, because instead of just 2D ICE scatter, because you can't do that. And then you can just rotate the angle, the X-plane through the 3 quadrants and color flow to determine if there's any leak or not. Remember your past compression as well. I do a lot of the 2D, but nowadays, in terms of compression, I use a lot of 3D MPR to measure the compression as well. Back to Steven's point, in terms of compression, where you actually measure it, further out proximally or distally as well. And so certainly for this patient, the device diameter, we had a 23% compression. Nothing exciting, but the patient did well. And in terms of the key points for this is really that pre-procedural planning. Your CT, your 4D ICE, make sure you remember, don't forget, besides analyzing your Watchman, your transeptal puncture, you can simulate your ICE imaging similarly for TEE based on your CT planning as well. Then you can find the correct catheter position. You can do, obviously, all your cases, moderate sedation and your rapid room turnaround, like Devi, doing 8 to 10 cases and same-day discharge. With that, thank you.
Thank you, Nadira, for that great overview. I think I have to say that Voudris is lucky to have you in the room and have that collaboration. Like sometimes most of us, when we do ICE cases, it's me doing both. And usually sometimes, it's the whole novology and digital steering has so much more value. I think many of us that do it independently lose a lot of the advantages of having that extra set of hands. But it's not possible in every lab to have that. Stephen just showed us that, his imager showed up at the end. And I'm sure when Muhammad's in a case, it's different. It's the wealth of knowledge that comes in with the second set of eyes that understands imaging is incredibly high.
Thank you. I mean, we truly, in terms of we are a rare breed, right, Mo? Because we have to be in all the other cases. So I can understand, to your point, this is such a fast-turning, efficient procedure, right? The Watchman. And so I really kudos to Mo steering this in the LAA space as well and working with vendors to automate and help with AI. Any comments on that, in your experience working with these vendors to help facilitate sites in the country where they don't have, like a second set of eyes? Any comments on that, Mo? Thank you. Any comments, Voudris, Vivian, Jason?
Yeah, so I think, with the 4D or 2D ICE, the points that have been brought up that are really good is doing the CT analysis ahead of time, because ICE does have its limitations. As great as the technology has evolved over time, it still has its limitations compared to TEE. But you can overcome a lot of those disadvantages if you do thorough CT analyses. So I do think it is very helpful to do all those analyses, see what anticipated views you should be getting, especially for new ICE users, so that you can, have an idea of what your appendage should look like in each of those views that you mentioned, the mitral, aortic, and pulmonic. And then, the measurements ahead of time so that you're not relying on the ICE measurements.
Thank you. And one question before Jason's talk is, what in this room filled with experienced LAA operators, what is your learning curve? Devi, like in terms of the LAA only. We know ICE use in LAA is easy, but what is it that, the learning curve in this? Like for tricuspid, right? Paul, for the LAA, there is, for the tricuspid in ICE, there's a learning curve. So how do you encourage, like, what would be your advice?
Yeah, I think it's a yeah. it's a great question. I think there are there was three aspects to learning. There's one is understanding how to get the ice into the LA, because today's technology that we have with 2D, 3D, 4D ice, that ice catheter has to be in the LA. So safely being able to get the ice catheter into the left atrium is one. The second is being able to get the necessary imaging, the aortic view, the mitral view, the PA view, being able to manipulate the catheter well enough to know. But also sometimes that is not, the PA view that you think is the PA view that's going to give you the widest is not the PA view. You sometimes need a low lateral view. So understanding that out of a CT to know where you need the ice catheter, just like Muhammed said, you can use TE, you can understand how the TE would look. You can also, TruePlan has that software. You can use ice, you can know where the ice needs to be to get the best dimensions. And then to know, how do you do a proper leak assessment, right? And then the third thing is understanding the knobs. If you're using 4D ice and, understanding how to do digital steering. So that's the learning curve. To me, I learned the first two segments because it was me because again, I use ice in the LA for my ablations since 2014. So that was not a learning thing for me. But the digital steering part, I had given up echo for a long time until I came into this space. And now I'm learning the echo machine again. So.
Yeah, I think the learning curve is different for the electrophysiologists who do this compared to the structural ICs that do this, because the EPs have so much experience using the ICE catheters and getting into the LA. Whereas I think for structural interventionalists, we're not as comfortable, not as familiar with it. I do recommend that if somebody's starting in the LAO space, to start with TE, and then if financially feasible, to do both ICE and TE at the same time, so that it really gives you that backup within the room of what you are looking at, what your view should be. And then still getting appropriate imaging of the left atrial appendage occlusion to ensure that you are getting a good result. I don't think that people should just be going straight into ICE imaging for their LAO if they haven't had experience before.
I think in the interest of time, we'll move on. Thank you so much, Nadira, again. And our next speaker is Jason Rogers, who will tell us his new technique of LA closure in 2025.
Thank you, Devi. So the title of my presentation is Together Better. So this case has some different structural components, but it's an 85-year-old transferred to our center, cardiogenic shock, really related to severe degenerative MR, probably with a ruptured cord, but she presents with AFib RVR. Interestingly, she had recent admissions for profound anemia while on Eliquis, as low as in the 4s. They couldn't find any reason, but she was still on Eliquis, and during this most recent presentation, her hemoglobin was 3.9. So she comes in shock on pressors. We did a right heart cath. She didn't have coronary disease, and we put in a balloon pump. This was her mitral valve anatomy. She has a popped cord in her posterior leaflet. The 3D on FOSS kind of shows the area pathology right in the middle of the valve. Interestingly, there is a large cleft in the posterior leaflet. And we did get images of her appendage as well, which were fairly unremarkable, and there was no thrombus in the appendage. So we have a lady who's, and here you can see it, the ostial diameter by TE was 24 by 17 and seems like adequate depth. So in summary, we have this lady who's in cardiogenic shock, needs something done with her mitral valve, but also has intolerance to anticoagulation. So the question is, what do we do for this particular lady? Do we just leave her alone, do surgery? I don't think so at 85. Do we just fix her valve, get her out of trouble, and come back and tackle the appendage later with a stage procedure, or do we do them together? So, thoughts?
I mean, the easiest part of all will be to do it together. I don't know if your hospital financiers will be happy with that, but you're in the neighborhood, you're like, you have a good transeptal, because for your mitral repair, you'll need that. And on your way out, it's in that appendage is approachable. So
Yeah.
you could,
How many people in the room have done a concomitant M-tier and appendage? So one, so two. So it seems to make sense because surgeons do it like every day, but we don't do it that often, probably mostly for reimbursement purposes. I did dig into this a little bit, and this is a little bit of the topic of my presentation was, the rationale for doing it together. It does make sense if we look at recent registries for M-tier, up to 60% of patients do have AF, and many of them are high surgical risk and have comorbidities that increase their risk of bleeding. So it does kind of make sense, just like concomitantly doing it with an AFib ablation. So what are really the challenges and the unknowns of doing this? So the first is, of course, there's no reimbursement. So this is a one-off, you can do it, but keep doing it, probably your administrators will give you a call. What sequence is optimal if we were going to do it together? Should we do the M-tier first? I mean, generally that would be a more complex procedure. And is there concern that putting an appendage device in might interfere with steering down to the valve? You would say, well, why put the patient through 2 GA procedures? Well, MitraClip is done with GA, but you could always come back and do LAO later under conscious sedation and ice. So maybe staging it is not so much of an imprint on the patient. The other thing that concerns me probably the most is that the MR, as we know, reduces your thromboembolic risk, right? The MR jet is washing the left atrium. So in a third of cases, when you do MitraClip, you see spontaneous echo contrast appear, and we like that, right? We say oh wow, we got rid of the MR, there's smoke in the left atrium. But is that really the best milieu at that point to be then implanting a LAAO device? And then what transeptal puncture site is optimal? We've learned every procedure has an optimal site. And are we making the best of everything or taking the worst of both? So you can see the red circle is where you would generally target for TIR. The green circle is kind of where we target for LAO, and there is an overlap there. So you can find a place where you can do both. But I would say that you're probably compromising a little bit for both procedures by doing it through a single transeptal. The other is what sequence. So if you do the MitraClip fourth, you have a 24 French hole in the groin, then you got to put an 18 French sheath in after that. So you're going to have bleeding. So you could put a 24 French Gore dry seal sheath in, but that's another $1,000 you've just added to your procedure. LAO requires contrast. MitraClip does not. You're introducing a new risk of AKI potentially in sicker patients. And the final thing is there's almost no data. There are some case series. The largest is 30 patients, and there's no randomized trial data. So we don't really have consensus on what is the optimal post-procedure pharmacology for this type of procedure. It appears to be feasible and safe, but we're not picking up lower frequency adverse events. So with all that in mind, I mean, I researched all this kind of after I did the case because the patient had the need for both and was sort of referred for both. The referring physician wanted both done, so that's what we did. But we chose the transeptal height not too high for MitraClip, so right at 4 centimeters. And her left atrium really wasn't that big, which I think is consistent with this being an acute MR situation. But you can see on the MPR we're getting a height of about 3.92 centimeters. So we did intentionally go a little lower. The clip procedure was pretty straightforward. We were able to grasp the area pathology in the middle, just next to the cleft. And got a good result, but did not make the MR go away completely because there was MR coming from the cleft. And as you can see, the valve is a little smaller, so really not room for a second clip. So based on this result, with a grading of 3, we were kind of done with this aspect of the procedure. You can see a little residual MR medial to the clip where that cleft is, but I'd say overall mild MR at this point. So there's the appendage on the left side lurking and waiting for us to come to it. So here then intraprocedurally, and because she was very sick, right, in the ICU and on pressors, and she already had a creatinine that was elevated, we didn't do pre-procedure CT. So we just did an on-table TE. So these are the views that we got. And the pectinates are always there waiting for us. We've seen many cases where pectinates are there and not necessarily seen on CT. So there are some pectinates, but probably doable. Here's the appendogram. Kind of reminds me of Steve's case a little bit. A lot of pectinates on that inferior posterior aspect of the appendage, but enough depth. So the question is, what size device? Probably on T we measured 25, 26 maximum, so we're looking at 31, but here it looks quite large for diameters, and we went in with a fixed curve sheath. So I probably would have done a true steer from now on, just given the suboptimal transeptal location. You can see we're kind of coming across more horizontally. But we chose a 35, and it had a proximal deployment. So we actually did a couple attempts with the 35. 2 attempts didn't really sit deep enough, kind of like your case, Steve. It was wanting to go proximal, I think, because of those pectinates. And then we went with a 31, which was basically uncompressed. I mean, it was very proximal and didn't have any compression. So ended up changing for a true steer and even a 27. We were able to get that deeper and get a better position, and I think we had a very nice result. But I would say the transeptal puncture location did make it a little more challenging than if we had just done this as a dedicated. So this is what it looks like at the end. You have the clip and the LAO together. The patient did well. She went home, just had her on aspirin only after the procedure. She didn't have any further bleeding. I have yet to see her back at 30 days because this literally case was just 2 weeks ago. So I would say in general that this is a safe procedure. The data show that it's feasible, that it's safe. Most of the series were done before steerable LAA sheaths, so it can be done without steerable sheaths. But I think it's probably better to use a steerable one. You still have to think, I think, about your transeptal site. You can't just go very high or very low because then you can't do the other procedure. And then I do think we really need we need more data in this area. So thank you.
Great case, Jason. My question, do you think we need a randomized controlled trial, just like in the EP world, AFib and Watchman on the same time?
Yeah, and that was what the other thing I was thinking about when I did this was I wanted to understand this more, and do we in fact need it? I mean, I think we do. The question is what is the treatable population? I mean, of course, there's 60% of patients who undergo MTIR that have AFib, but a lot of those don't really have active or ongoing bleeding issues that we would put an appendage, an LAA device in them, even if they didn't have, so we're looking at maybe, and then I do have concern about this smoke issue, the fact that this acute reduction in the left atrium, left atrial blood velocity, that create this thrombotic milieu. So yeah, I think those things are all things we need to study before we start doing this.
Well, on the other side, Jason, the concern always was that if you have an MR jet, then you might not endothelialize because the jet always hitting the device as well. So there's two sides to that story, and I guess we have more to learn on it. But as an EP who's not going to be referred an MR patient, if I get a patient inter-procedure, they're getting the TE for the first time, they had a CT, and I see severe MR, should I stop or should I continue with my LA closure and then refer for mitral valve?
I think if you're there and if they had an indication for closure, I would just go ahead and do that. And then patient can always have, where we see it is if you want it late, then I would say stop, let us fix the MR first, and then your ablation may be effective. So that's, at least in our practice, that's what I've seen. But if you're just there, I would probably just close it, unless there is some crazy pathology where we couldn't clip it and they just needed an operation.
Yeah, the ablation is an important point. I guess when we have MR, we are referring them for mitral intervention first, because we're definitely seeing better success rates with ablations once the mitral valve is taken care of. And I think there's a trial that's currently enrolling, looking at that as well. So, and is there a point in, do you do the appendage closure first or mitral first, or does it matter if there's no ablation involved?
I think you can do it in either. I think one series they did the Watchman first, and then the mitral clip, and then the other it was kind of the other way around. So I think it's dealer's choice at this point.
I mean, I think in your case, it's difficult because the patient had indications for both procedures, but I think as far as staging the procedure, it kind of depends on the clinical situation. Does the patient need a Watchman more, or do they need a mitral intervention more, right? Because if your patient just incidentally had MR, but really just came in hemorrhagic shock, if you were to do the clip and now your gradient is high because of the clip, just like an incidentally found MR, severe MR that you decide to do concomitantly. Now you have an elevated gradient, and the real issue is closing the appendage. Are you doing the patient a disservice by putting in the what they really need afterwards and having the issues of DRT afterwards? So I think as to what should be done first, it really depends on if the patient has a strong indication for one versus the other.
Just like for steering, I don't think it affects it significantly for the mitral steering. I mean, there's a good flexion, like, yes,
Agreed.
a little cautious, but we're cautious with the appendage regardless because you're trying not to enter it. So I don't think I would ever take the patient out of the table and be like, no, we don't have your appendage closed today because they cannot do your mitral
I guess
procedure.
I would generally favor doing the clip first because that's an acute intervention that has an acute benefit to the patient that we know can help them immediately, whereas Watchman, right, is a prophylactic procedure. So, but I think you could do it either way.
All right. Thank you so much,
All right,
Jason.
thank
In
you.
the interest of time, we'll give a break for 30 minutes and then we'll regroup at 4 for the next session on another left atrial appendage closure. Thank you.